Hello, coders. Good morning, good evening, good afternoon, all depending upon where you're joining us from. Welcome, welcome, welcome to the CPT Guideline Mastery Session with AMCI. First of all, let me know, coders, how are you all doing and how do I sound? Am I audible? Is my mic doing good? Let me know in the chat. Okay, I can see a lot of greetings. Good afternoon. All right, all right. Thank you. Thank you for letting me know. So, once again, coders, welcome back to another CPT guideline session. It is always great to see you all coming back week after week, investing your time in strengthening your coding foundation. So, I don't want to waste any more time. So, let's dive in and make today's session productive and a confidence building one. All right. So, let's begin by reading out the copyrights. Copyright CPT, Copyright 2026, American Medical Association, all right reserved. CPC is a registered trademark of AAPC. AAPC content found within this presentation is a copyright of AAPC. The keyword concept FTR, CHUN, AMCI FAB 7, AMCI ICD 10, Flip Tab, and MCG are the trademark of AMCI. The credentials CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC. AMCI do not own right to these credentials. The credentials CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA. AMCI do not own right to these credentials. Okay, so today, coders, we are diving into the topics that are big for both exam and real world coding. Yes, we will be discussing the skull based surgery coding, destruction of or destruction by neurolytic agent, as well as we will be discussing about the chemodenervation coding procedure. So, a lot of interesting topic to discuss today. And in your CPT manual, the codes for today's topic, the skull based surgery, destruction by neurolytic agent, and chemodenervation, all are found under the nervous system chapter. And the skull based surgery codes are reported from 61580 to 61619, and the destruction of neurolytic agent and chemodenervation codes are reported from 64600 to 64681. All right, so this is where you find these codes, and let's begin with the skull based surgery coding. And before we jump into skull based coding, surgery coding, we need to get one thing crystal clear. What exactly is a skull base? So think of the skull base as the floor of the skull. Yes, it is a foundation that brain literally sits on. Now, here is an important part. Skull base act as a divider. It separates the brain from the critical structures below it, including your face, nasal cavity, the paranasal sinus, ear structures, and even the upper spine and the brainstem. Now, here's a key concept you must remember for both anatomy and CPT coding. The skull base is classified into three areas. All right. And these three areas are first, your anterior cranial fossa, followed by middle cranial fossa, and then comes the posterior cranial fossa. All right, are we good so far, Goddess? This is about the basic anatomy of your skull base. So let's discuss in detail in the next slide. So anterior cranial fossa, let's talk about that. Anterior cranial fossa, this is the front portion of the skull base, and it supports the frontal lobes and lies down or lies above the eyes and nasal cavity. So you can see the anterior cranial fossa over here. Then comes the middle cranial fossa over here, just below it. This is a central portion of the skull base, and it houses the temporal bones and contains major neurovascular structures. And Then it comes posterior cranial fossa over here. Yes, this is the back and the deepest portion of the skull base. It supports the cerebellum and brainstem and connects to the upper spinal cord. So, why does matter for coding? You might ask, why does the anatomy matter for this coding? For the coding, yes, it matters because CPT skull-based procedure codes are organized based on these three cranial fossa. All right. And easy tip to memorize is that anterior equals is equal to your front, middle will be the center, and posterior will be the back. All right, that's a quick tip. Now, skull base surgery involves a lesion located at the base of the skull, which I've just mentioned. So it might involve the lesions at the anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa as well. So these procedures frequently require multidisciplinary team. That means multiple surgeons, often from different specialty, may work together during the same operative session. Now, this is actually indeed a complex procedure. The skull-based surgeries are really complex procedure, and it involves the specialist from different specialty, right? So these procedures are not typically staged. Why? Because delaying the closure would significantly increase the risk of infection, including the meningitis and osteomyelitis. So, during the same operative session, the surgeon will aim for the definitive closure of the dura, the subcutaneous tissue, and the skin. All right, so skull based procedures are, as I said, classified into three distinct components. So, first comes the approach, then comes the definitive procedure, and the third one is the repair or reconstruction procedure. All right, so now let's discuss in depth about these three procedures. First is the approach, right? An approach is performed solely to obtain adequate exposure to the skull base lesion. In simple terms, it describes how the surgeon gets there, not what the surgeon does once they are in. All right. So the approach procedure explains how a surgeon accesses the skull base, and it is classified based on the anatomical areas involved, including your anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa, as well as brainstem and upper spinal cord at times. So CPT organizes the skull base approach codes around these anatomical regions. So you can see these are the approach procedure codes and how they are classified. You can see they are classified according to the cranial fossa. You have approach procedures on the anterior cranial fossa, approach procedures on the middle cranial fossa, as well as the posterior cranial fossa. All right, let me know, Curtis. How are you doing? Are we good so far? Are you understanding? Let me know in the chat. Okay, so anterior cranial fossa approach codes are ranging from 61580 to 61586. And in that, 61581 through 61583 uses a craniofacial approach. That means it's a combination of neurosurgical and facial surgical technique used to access deep seated lesions of the skull base by approaching them through both cranium and the face. So that is your approach, craniofacial approach. All right. Then we have 61580 and 585 that uses orbitocranial approach. Okay. Now this is a combination of orbital roots with the cranial roots. That's how it got its name. That it got its name orbito. I think okay. Let just give me a second. Orbitocranial approach. All right. And next we have, what do we have next? We have 61585 that is also using orbitocranial approach. And next there is a 61586. So here the physician exposes the anterior cranial fossa by combination of techniques like bicoronal, transzygomatic, and Leaford 1 osteotomy approach. So it involves multiple techniques And then comes next is about the middle cranial fossa, and the CPT codes ranges from 61590 to 61592. So CPT 61590 describes the infratemporal preauricular approach to the middle cranial fossa. So in this approach, the surgeon makes incision in front of the ear. That's how it got the term preauricular. It will be done, the incision will be made in front of the ear. All right, and it passes through the infratemporal fossa to gain access to the middle cranial fossa. And then we have CPT code 61591. This describes an infratemporal postauricular approach. That means, yes, that means postauricular means it's behind the ear. And then we have 61592. Yes, it uses orbitocranial zygomatic approach. So here again, a combination of approaches used, techniques is used, cranial access as well as zygomatic osteotomy technique is used for orbitocranial zygomatic approach. And finally, we have posterior cranial fossa approach. So here the CPT codes are from 61595 to 61598, and all these codes describe different approach to the posterior cranial fossa. So here the term trans means across or through. So each code descriptor tells which approach was performed. You have 61595, that is for transtemporal, which means through the temporal bone. Then we have 61596, that is transcochlear, that means through the cochlea. And 61597, that means transcondylar, which means through the condyle structure. And finally, we have 61598, that is transpetrosal. All right, so trans means through. And this is how the approach procedures are classified. And it is the only important thing you have to note is to identify which approach has been used. All right. Okay. So now let's move on to the definitive procedure, the second part of the skull base procedure. So, definitive procedure is performed to treat the lesion. Okay, it talks about why they went there, why they went inside the skull. It is to treat the lesion, right? So this is the main therapeutic component of the skull base surgery, and the definitive procedure may involve procedures such as your biopsy, repair, resection, excision, and when appropriate, a definitive procedure may include the primary closure of the dura, mucous membrane, as well as skin. So, as I said, this is the main therapeutic component of the surgery. This is what a surgeon does once he gets inside. So, we have covered the approach. Now, we have covered the definitive procedure. Let's move on to the third part. Okay, before that, let's look into the CPT codes for the definitive procedure. Again, all these definitive procedures involve treating the lesions at the base of the skull, such as tumors, neoplastic new tumors, the vascular lesion, the infectious lesions, and these codes are also grouped as like grouped into three, as of like you have base of the anterior cranial fossa, base of the middle cranial fossa, and base of the posterior cranial fossa, and each location is further divided based on the depth of involvement, like whether it was an extradural involvement. Extradural means lesion is outside the dura, and then we have intradural involvement, which means lesion extends inside the dura. Okay, that's the difference between an extradural and an intradural. And when the procedure is intradural, these codes typically includes the dural repair as well. Okay, so this is how the definitive procedures are classified. The CPT codes are classified. And now we move to the final phase of the skull base surgery, that is talking about the repair and reconstruction procedure. So these procedures are performed to repair the defect that remains after a definitive procedure has been completed. So once a definitive procedure is completed, if there is any repair needed to be done, that's where we code these CPT codes. All right. And the repair and reconstruction procedures are reported separately only when the work is extensive. That's the key word here, extensive. If it's not an extensive repair perform, you should not code them. All right. And the CPT codes are 61618 and 61619. Okay. So it's time for us to move on to the FTRs, the facts to remember about the skull base surgery. You can find them in our MCG manual. All right. So let's review the facts to remember while coding the skull base procedure. Number one, determine the approach and the dural involvement. So first of all, you have to see what approach was used. Was it an anterior approach, middle cranial fossa approach, or posterior cranial fossa approach? All right, that's a very important point. Second point is also equally important. Match the approach with the definitive procedure. So once you have identified what approach has been used, then you have to match that approach with a definitive procedure. So if you have, let's say, the example of an anterior cranial fossa approach, then the definitive procedure should be also on an anterior cranial fossa. All right. And the third point is to use a modifier 51 for multiple procedure by same physician. Okay, so if the same physician does the multiple procedures, such as if same physician does an approach as well as definitive procedure, you can use the modifier 51. Fourth point, repair reconstruction is separate if extensive grafting, dural or skin cranioplasty, local or regional myocutaneous pedicle slabs, and important thing to note is that code separately if different physician performs different procedure and do not use a modifier 62. That means if two different physician or surgeons perform two different procedures, you can code them separately and you should not use a 62 modifier in those circumstances. All right, so these are our FTRs, and this was what I was talking about. So you can see on the left hand side, you have all the approaches classified based on the anatomical regions. And on the right hand side, you have all the definitive procedure. So once you identify your approach, it should match with your definitive procedure. So if your approach is on anterior cranial fossa, your your procedure, definitive procedure should be an anterior cranial fossa procedure. Likewise, with the middle cranial fossa and the posterior cranial fossa. Okay, all right. So let's move on to the next topic of the day. We are going to discuss about the destruction by neurolytic agent, including your chemical, thermal, electrical, or radio frequency. Also, we will be discussing about the chemodenervation topic. All right, everyone. Let's talk about the neurolytic destruction, also known as a neurolytic procedure. So, neurolytic destruction procedure is a procedure where the physician will intentionally, so this is the keyword, intentionally destroys specific nerve fibers to stop pain signal from reaching the brain. All right, so that is a way to control the pain, right? And this is not a temporary fix. Okay, this is not a temporary fix. This is done when the goal is long term and often a permanent pain relief. And the nerve can be deliberately destroyed using different methods, including the chemicals, yes, including the chemicals, or the thermal method. You can use the heat of a temperature greater than or equal to 80 degrees Celsius. Then can be done by using electric and radio frequency, continuous radio frequency ablation. So radio frequency ablation is one of the most common used method. So no matter the technique, the objective is same: interrupt the pain pathway by disabling the nerve itself. And this procedure is primarily used for severe chronic pain and cancer related pain. Also, for the pain that has failed uh, conservative treatment or temporary treatment. So, think of it as a last line or a definitive pain control option. Okay. So let's look into the guidelines. So these codes or these services are reported with the CPT code ranging from 64600 to 64681. They include the injection of the therapeutic agents such as corticosteroids, or if an therapeutic injection is also given, that is not separately coded. All right. And if the technique used is actually not destructive to the nerve, or for example, if the technique used is a pulsed radio frequency which does not destroy the nerve, then you do not report the destruction code. Instead, you will use the unlisted code, that is 64999. All right, this is an unlisted nervous system procedure code. And yeah, I will also touch on some of the chemodenervation code, which we will discuss on the later stage. So here, since we have it on our slide, I will discuss that as well. So certain body parts have their own chemodenervation codes, such as internal anal sphincter, the bladder, the external ocular muscles. So when these apply, you must use the site-specific code and not the general chemodenervation code. So you will have to go to those specific CPT codes and use them from those chapters, not from this chapter. All right. Okay. All right. So CPT organizes the procedure by what nerve or nerve group is being treated, such as cranial nerves, like the trigeminal branches, or the spinal or peripheral nerves, joint intervening nerves, muscles, or the glands supplied by specific nerve. And another key thing is that many of these procedures may involve imaging or EMG guidance. So CPT is very specific of when the guidance are included, or when it may be reported separately, and when it is not allowed together. So always have an eye on these parenthetical guidelines, and you can churn your manual as well. So that will be really helpful. All right. Okay, so next section focus on paravertebral facet joint nerves. And once you understand the anatomy, these coding rules makes total sense. So a facet joint is a small synovial joint formed between the articular process of the adjacent vertebrae in the spine. And these joints are present at different levels like cervical, thoracic, and lumbar levels. So they play a key role in spine movement, the stability, and unfortunately also for a chronic spine pain. So facet joints are innervated by the medial branch nerves of the dorsal rami of spinal nerves. And you can see the facet joint are, yeah, it's written here. The facet joints are innervated by the medial branch nerves of the dorsal rami spine, and two medial branches nerves innervate at each joint. So that's why more than one nerve may be needed to be targeted. So while coding, you have to keep in mind that the coding for a destruction by neurolytic agent of the paravertebral facet joint nerve is done based on the facet joint treated, not on the basis of number of nerves that is destroyed. All right, so you code as per the number of facet joint treated, not by the number of nerves that has been treated. Okay, so that's a guideline which you have to keep in mind. And here you can see the CPT organizes these codes using like two questions: which spinal region, whether it's a cervical, thoracic, or lumbar or sacral. You can see 64633 is for the cervical or thoracic single facet joint. And the second question will be how many facet joints are treated. Okay. So you have to use the add-on codes if there is more than one facet joint that is treated. So here you can see 64634. You have add-on code for cervical or thoracic, each additional facet joint, and you have 64635 that is for single facet joint at lumbar or sacral level, and 64636 that is for lumbar or sacral level additional facet joint. Okay. And one thing you have to note is that, or keep in mind, is that you should not report 64633 to 64636 with 77003 or 77012. Why? Because image guidance are already included in these codes. So do not report image guidance along with these codes. And here is a parenthetical guideline that you have to churn and you have to keep in mind while coding these services. So when you are coding for a bilateral procedure, bilateral restriction of the paravertebral facet joint by neurolytic agent at two levels, all right, at two different levels. So for the first level, the base code, you can use 64633 or 64635. And if the bilateral level injection or the destruction has been performed, you will report these codes with a modifier 50. And for the second level, you cannot report them with a 50 modifier. Instead, you will report those add-on codes with a quantity 2. So you can see these add-on codes for bilateral procedure, report 64634 and 64636 twice. Do not report a 50 modifier in conjunction with 64634 or 64636. So you cannot report these add-on codes over the 50 modifier. So that's something you have to keep in mind and churn in your manual as well. So do not report 64633 and 64636 for non-thermal facet denervation, chemical, low-grade, thermal less than 80 degree or pulse or radio frequency as well. So instead, you will report these services with the unlisted code 64999. All right, so you can keep that as well in mind. And let's move on. I think, yeah, this is going to be the last topic. So let's talk about chemodenervation. Chemodenervation is the injection of chemical agents. Mostly used is the botulinum toxin. You must have heard about it to temporarily block the nerve signals to the muscles and the glands. So here in the chemodenervation, the key word is temporary, while in the previous slide you saw that it was a destruction, right? This is temporary, while other one is a permanent. So here key characteristic is that these are reversible procedures. The nerve is not destroyed and effects wear off over the time. And this nerve inactivation, this is a nerve inactivation and not a nerve destruction procedure. And chemodenervation is commonly used to treat the dystonia, spasticity, chronic migraine, and sometimes hyperhidrosis. All right, and you also have to remember that do not report separately the diagnostic injection, therapeutic injection, as well as contrast injection if they are performed along with the chemodenervation procedures. And yes, so these are the chemodenervation code. You have 64642 to 64645. That is coding for chemodenervation of the extremity. So you have 64642, that is for chemodenervation of one extremity, 1 to 4 muscles. So you can see this example. You have for example, you have a left hand and injection or the chemodenervation procedure is performed on 3 of these muscles which you see on the screen. At these circumstances, you will use 64642. And if the same procedure is performed on your other opposite laterality hand as well, like your right hand, then you will report 64643 along with 64642. Okay, so that's a CPT code for your additional extremity for 1 to 4 muscle. Similarly, you have chemodenervation code for one extremity for with 5 or more muscles. So here is an example. You have a left leg where chemodenervation is performed on 5 or more muscles. Yes, 5 or more muscles. Then you will use 64644. And if the same procedure is performed on the opposite lateral or opposite leg, that would be your right leg, then you will use 64645. Okay, that is for each additional extremity, five or more muscles. That is important. And then you have code for chemodenervation of the trunk muscle. Similarly, 1 to 5 muscles, you would use 64646, and 6 or more muscles, you would use 64647. And coders have a look into these parenthetical guidelines as well. All right. Yes. Now let's look into the guidelines. 64642, 64643, 64644, and 64645 are reported once per extremity, maximum up to 4 combined procedure. And you have to use 64646 or 64647 for the trunk muscles. Use add-on codes for additional muscles and code one base code per session. All right. So only one base code should be used per session. Also report chemodenervation agents separately if applicable. Finally, diagnostic injections are bundled. All right, so these are some other few chemodenervation CPT codes. You can also have a look into these codes. These are based on the muscles and the glands. All right, coders. So we have learned a lot today. It's time to test what we have learned. And are you ready, coders? Are you ready to do the coding exercise? Let's apply those guidelines what we learned. Okay, here we go. Exercise number one. Of the following answers, which best describe correct CPT coding for this procedure? Your options are 64635, option B 64633, option C 64999, option D 64635 A 64-year-old patient with chronic low back pain undergoes pulse radiofrequency treatment of the lumbar medial branch nerve supplying the L4 L5 facet joint. The procedure is performed under fluoroscopic guidance. Of the following answers, which best describe the CPT coding for this procedure? What say you, coders? You got 2.5 minutes to answer this one. Okay, you are all going to rock this scenario. So be forensic. That is my tip for this scenario. Okay, go ahead, coders. Your time already has begun. All right, coders. I can see only a couple of answers in the chat. How about the rest of you? Go ahead and place your best answers. Don't worry, even if you get it wrong. Okay, so participate in these exercises, and I will walk you through this one. All right. So what we have here, we have a patient who is 64-year-old, presents for a pulse or radio frequency treatment for the lumbar medial branch nerves, right? All right. So I can see the answers are coming up now. So we have six, uh, yes, 64633, which is for yes, 64633, which is for destruction by neurolytic agent, paravertebral facet joint nerves, and the location is or the level is cervical or thoracic. Now, we had a radiofrequency, pulse radiofrequency treatment at L4 and L5. Those are your lumbar facet joints, right? L4 and L5, and not cervical or thoracic. So I can easily eliminate option 64633, that is option B. And 64635 is coding for a destruction of the neurolytic agent at lumbar or sacral single facet joint. So that looks like a good code. But let's see. So option D is coding for 64635 with 77003. And we have a parenthetical guideline which states that do not report 64633 to 636 with in conjunction with 77003 and 77012. So that's incorrect. We cannot quote them together. The image guidance is included. That's incorrect. And now we are left with option A and option C. Option A is coding for 64635. Option C is coding for 64999, which is an unlisted code, right? Now, here is the catch coders. So we have a guideline which we discussed in the beginning, right? And the guideline states that do not report code labeled for destruction when using therapies that are not destructive of the target nerve, such as they have given an example of pulse radio frequency as well. And there is one more guideline over here that states that do not report 64633, 64634, 64635, and 64636 for non-thermal facet joint denervation, including chemical, low-grade thermal energies, and or any form of pulsed radio frequency. To appropriately report any of these modalities, use 64999, that is unlisted code. And now going back to our scenario, if you look at our scenario, it said that patient underwent, yes, over here it says that the chronic low back pain undergoes pulsed radio frequency treatment, right? So it's the exact treatment which was mentioned over here in the guideline as well. So if you have a pulse radio frequency treatment, you are not going to code for 64635. Instead, you have to report 64999, which is an unlisted modal unlisted CPT code. Okay, coders, let me know. How are you all doing? Let me know in the chat. Was this an aha moment? Yes, that's why I said be a little bit forensic on this scenario. Okay, coders, let me know. Did the explanation help? Yes, that was an aha moment. So a bit more forensic, we would have got that one. So great job, great participation. I can see a lot of aha moment in the chat. So good work, everyone. Let's move on to the next exercise. Exercise number 2. Here is your question. Of the following answers, which best describe the CPT, correct CPT coding for this procedure? Options are option A, 64635, 50 modifier, 64636, 50 modifier, option B, 64635 times 2, 64636 times 2, option C, 64635 with a 50 modifier, 64636 times 2, option D, 64635 times 2, 64636 with a 50 modifier. A 68-year-old patient with a chronic lumbar facet mediated low back pain undergoes radiofrequency ablation of the medial branch nerves innervating the L4, L5, and L5, S1 facet joints on both the right and left sides during the same session. The procedures are performed under fluoroscopic guidance of the following answers, which best describe the CPT, correct CPT code for this procedure, and coders. If time already begun, you can place your answers in the chat. All right, coders, I can see some great timers is still running on, but I will walk you through this one because we are running short of time. And great answers. You all are rocking it in the chat, by the way. Excellent coding. So you guys got the guidelines. You all were forensic with this scenario also. Okay, so what we have here, we have the CPT code 64635 that is coding for destruction by neurolytic agent. The level is lumbar or sacral single facet joint. Then we have 64636, right? Yes, 64636 that is coding for destruction by neurolytic agent. The level is lumbar or sacral, each additional facet join. So that is your add-on code. And if you look into the procedure, we have a destruction or by neurolytic agent performed at L4 and L5. That is one of your facet, and then we have L5 and S1. That's your second one. Okay, so it's a two different levels. The destruction has been performed, and it's time for us to look into the code options that we are having. Okay, so we have a parenthetical guideline. If you notice that you have a parenthetical guideline under 64635, which states that for the bilateral procedures, report 64635 with a modifier 50. Right? Am I right, Curtis? Yes. So that would help me eliminate option B and option D because they are coding for two quantities of 64635, which is incorrect as per the guidelines. So parenthetical guideline asks us to report 64635 with the 50 modifiers. There you go. So your two options are B and D are wrong. We are left with option A and option C. Okay, now we have to figure out which is the correct answer. And again, if you remember, I told you you have to keep an eye on these parenthetical guidelines just before reviewing the guidelines in the beginning, right? So if you look into the next parenthetical guideline that is under 64636, you can see that for bilateral procedures, report 64636 twice and do not report a 50 modifier in conjunction with 64636. That means option C is incorrect. Sorry, option A is incorrect. Option A codes for 64636 with a 50 modifier. And if you look into the procedure, we had a destruction performed at bilateral two levels, right? At both right and left at two levels, L for L5 and S for L5 and S1. And that just by following the parenthetical guideline, I arrived at the correct answer, and that would be option C, which is 6463550 modifier and 64636 times 2. All right, coders, how are you all doing? If you learn something, as Misty always say, that is priceless. Okay, so don't worry if you got it wrong, and I hope the explanation helped. So let's move on to the next scenario. Quickly, let's move on to the third scenario for the day. Of the following answers, which best describe the correct CPT coding for this procedure? Option A 64644. Option B, 64644, 64643. Option B 64642, 64644. Option C 64647. Option D 64642, 64645. A 56-year-old patient with a history of stroke presents with a significant muscle spasticity affecting the daily activities. After failing conservative management, the patient is scheduled for botulinum toxin injection. During the visit, the physician carefully evaluates the involved muscles and performs chemodenervation in single session. In the right upper extremity, botulinum toxin is injected into six different muscles to relieve the severe spasticity, while in the left upper extremity, the physician injects botulinum toxin into three muscles. All injection sites, dosage, and the patient's immediate response to the treatment were clearly documented. Of the following, which best describe the correct CPT coding for this procedure? Okay. All right. So we have some great interesting answers uh coming in the chat. Okay. All right. So let's review it. Okay. So First of all, I did my inventory, what the procedure was performed. We had a chemodenervation procedure performed here, and botulinum toxin was used. It was done on the right upper extremity. There were six muscles which on which the chemodenervation was performed, and the left upper extremity there was three muscles on which the chemodenervation was performed. All right. So keeping that in mind, 64646. Sorry, what that was 64646. Yes, that is for option C. 64647 is coding for chemodenervation of the trunk muscle, six or more muscles. Okay, so we didn't had a chemodenervation performed on the trunk muscles. We had them done on the extremities, on the right upper extremity and left upper extremity. So sorry, option C has to go. It is incorrect. It's coding for the wrong location. Now let's look into the option B, 64642 and 64644. 64642 is coding for chemodenervation of one extremity, 1 to 4 muscles, and 64644 is coding for chemodenervation of one extremity, each additional extremity with 5 or more muscles, right? Yes. So this is incorrect because they are coding for two base codes. Yes. So yeah, 64644. Sorry, I got it confused. 64644 is coding for chemodenervation of one extremity, five or more muscles. So 64642 and 64644 both are base code. And we have from our MCG FTR, it says that use only one add-on code, sorry, one base code per session. Yes, code one base code per session. So you can use two base codes per session. So that's why I would say option B is also incorrect. Now we're left with option A and D. So this is interesting. Option D is coding for 64642, which is chemodenervation of one extremity, 1 to 4 muscle, and 64645 is coding for chemodenervation of one extremity, each additional extremity, 5 or more muscles, right? And if you carefully read once again the parenthetical guideline here, it says that use 64645 in conjunction with 64644, right? So you can only use 64645 in conjunction with the 64644, not with uh not with 64642. And that makes option D incorrect. And option A, as most of you have said, is the correct answer, which code for 64644. That is for chemodenervation of one extremity that covers five or more muscles. So right upper extremity is covered here with 64644 and 64643, which is the add-on code that is for chemodenervation, one extremity, each additional extremity, 1 to 4 muscles. And again, here also in the parenthetical guideline, you can see you can use 64643 in conjunction with both 64642 and 64644. So that is safe to use, and it makes option A the correct answer. Wonderful job, coders. And let's move on to the last scenario. Exercise number three. Oh, sorry, this is exercise number four. Okay, I've got it wrong. This is exercise number four, and here's your question, Goddess. Of the following answers, which best describe the correct CPT coding for the procedure? Option A, 61583, 61601 with a 51 modifier. Option B, Option B, 61582, 61600 with a 51 modifier. Option C, 61581, 61600 with a 51 modifier. Option D, 61582, 61605 with a 51 modifier. A 58-year-old patient presents with a worsening headache and visual changes. Imaging studies reveal the neoplastic lesion involving base of the anterior cranial fossa confined to extradural space. Due to the complex skull base location, surgical intervention is planned during the single operative session. Same surgeon, neurosurgeon, first performs a craniofacial extradural approach to the anterior cranial fossa, including bifrontal craniotomy, elevation of the frontal lobes, osteotomy of the skull base to the obtain adequate exposure to the lesion. After completing the approach, the surgeon proceeds to excise the extradural tumor, from the base of the anterior cranial fossa. Following the tumor removal, dura is inspected and found to be intact. Primary closure of the dura and the surgical site is performed without need for extensive dural grafting, cranioplasty, or flap reconstruction. Of the following answers, which best describe the correct CPT procedure coding for this procedure? All right, Kodas, quickly, you got 2.5 minutes to answer this one. Awesome, awesome, awesome job. Outstanding. You all even started answering way before the timer went off. Great answers. Excellent job, Curtis. So, okay, let me quickly walk you through this one as well. I've got my inventory, neoplastic lesion, base of the anterior cranial fossa, a craniofacial extradural approach, and a surgical excision of the extradural tumor was performed in this scenario. Wonderful answers. Answers are coming through. Great job, everyone. Excellent. Impressive. Okay, so let me know, Curtis. What was the location of the lesion in this scenario? At which location of the skull base is the lesion located? Is it in the anterior cranial fossa? Was it in the middle or the posterior cranial fossa? So first you have to identify the approach, right? So the lesion was in the anterior cranial fossa. Am I correct? Join with me in the chat. Okay, yes, it was anterior cranial fossa, and the approach is also an anterior cranial fossa. You can read over here. Yes, during the single operative session, same neurosurgeon first performs the craniofacial extradural approach to the anterior cranial fossa. That is your keyword. So once you have identified the approach, now you have to identify the definitive procedure. So definitive procedure is also would be on the anterior cranial fossa, right? After completing the approach, the surgeon proceeded to excise the extradural tumor from the base of anterior cranial fossa. Yes. So your approach and procedure is on anterior cranial fossa. All right, so now let's look into the CPT codes 61582. That is coding for a craniofacial approach to the anterior cranial fossa, extradural, extradural including the lateral rhinotomy, ethmoidectomy, sphenoidectomy without I'm sorry, I was reading the wrong CPT code. So 61582 is coding for craniofacial approach to the anterior cranial fossa, extradural including unilateral or bifrontal craniotomy, elevation of the frontal lobes, osteotomy of the base of anterior cranial fossa. So you can see all these keywords, all these procedure performed in the approach that was performed in our scenario. There was a bifrontal craniotomy, elevation of the frontal lobes, and osteotomy of the skull base also performed, right? Yes. So all these procedures was performed. So 61582, it looks like a good CPT code. Yes. So I think we figured out the code for the approach. Let's look into the option D, which is coding for 61582 and 61605. Now 61605 is for a resection of or excision of the neoplastic, vascular, or infectious lesion infratemporal fossa, parapharyngeal space, and petrous apex extradural. Now, I can straight away say this is a wrong code because you can see this is under the base of middle cranial fossa section, right? This falls under middle cranial fossa. I've already identified that my approach is anterior cranial fossa approach. My definitive procedure is anterior cranial fossa definitive procedure, right? So yes, straight away I can say this is a wrong one. Your approach is not matching your definitive procedure, referring to our MCG guideline, the FTR. You have to, the second point says that match the approach with your definitive procedure. Yes, so that rule is not followed here. Option D has to go. Let's look into the next one, 61583, which is option A, that is coding for an intradural, sorry, craniofacial approach to the anterior cranial fossa, intradural, including unilateral or bilateral craniotomy. Now, this is intradural. We are dealing with an extradural tumor, not an intradural tumor. So, again, option A is incorrect as well. Now, we are left with option B and option C. So, let's see what they are coding for. Okay, most of you have went with option B. So option C is coding for 61581. That includes extradural, that includes craniofacial approach to anterior cranial fossa, extradural, including lateral rhinotomy, orbital extenuation, ethmoidectomy. I don't see orbital extenuation and ethmoidectomy performed in our scenario. So that will make option A incorrect as well. No, option C incorrect as well. And the correct answer, as all of you have said, is option B. See how easy a skull base surgery coding is. It's a complex procedure, by the way, but coding is much easy if you follow the guidelines. Okay, if you get the concept correct. So you all did a fantastic job. So let me wind up by some quick ball exercise. Yes, the rapid fire exercise. All right, Curtis. So the first question: during a neurolytic nerve destruction procedure, the physician injects corticosteroid through the same needle track. What should be coded here? Option A, report the injection separately. Option B, injection is included in the destruction code. Option C, use diagnostic injection code. Option D, use an unlisted code. What say you, coders? This is a rapid fire round, and I expect everyone to please answer quickly. Go ahead, coders. Okay, I have first answer in the chat. So we have first one member has already placed. Okay, yes, Star Wars Girls has already placed the answer in the chat. How about the rest of you? Go ahead, go ahead. If you know the guidelines, if you have carefully listened to the guidelines, you will get it right. Okay, here comes the next. All right, everyone is now joining, and the chat is on fire. So yes, I would say you all are right. Injection is included in the destruction code. Great job. Excellent. Yes, here's a guideline which states that the code 64600 to 64681 includes the injection of other therapeutic agents as well. Do not code or report the diagnostic or therapeutic injections separately. Excellent job. Next question code is: a physician treats a facet joint nerves using low grade thermal energy below 80 degrees Celsius. What should be coded? Use a facet joint destruction codes. Option B, Low grade thermal energy qualifies as destruction. Option C, use an unlisted procedure. Option D, report diagnostic injection. What say you, coders? You did an exercise similar to this today. Okay, great, great. See, that's how we learn. So that's a perfect. I can see you all are placing correct answers in the chat. Yes. So once you get it wrong, that's not a big deal. If you learn something, that is priceless and that is beautiful. So I can see you all have learned from your mistakes. Excellent job. All right. Anyone more to place the answers in the chat? Go ahead. I will wait for a couple more seconds. All right. And yes, the correct code is going to be option C, use the unlisted procedure. And here we go. Here is a guideline which you need to refer. Okay, this is a guideline you need to refer to not report 64633 to 64636 for non-thermal facet joint denervation, including chemical, low-grade thermal energy, or any form of pulsed radio frequency. So great job. Let's look into the third question. During the single skull base surgery, one surgeon performs a procedure to gain exposure to the lesion and then performs a procedure to excise the lesion. Both procedures are completed during the same operative session. What should be coded here? Report only the definitive procedure. Option B, report only the approach procedure. Option C, report both procedure happened a 51 modifier to the secondary procedure, and option D, report both procedure without modifier. What say you, coders? All right, great, great, great answers. So let me quickly show you the answers. Yes, it is option C. Report both procedures and happen 51 modifier to the secondary procedure. And here you go. Here we go. Here is your guideline that you have to refer. And let's move on to the next one. During the complex skull base surgery, one surgeon performs the approach procedure to expose a lesion, and the second surgeon excises the lesion. And third surgeon performs a reconstruction of the surgical defect. What should be coded? Should we report a primary surgeon? Should Option A, the primary surgeon reports all the procedure with the 51 modifier. Option B, use 62 modifier. Option C, only the definitive procedure is reported. Option D, each surgeon reports only the procedure personally performed. What say you, coders? Please your best answers in. Don't worry, even if we get it wrong. What do you think? Which is the correct one? Okay, yes. Yes, that is the correct answer is going to be option D. Each surgeon reports only the procedure personally performed. So here's the guideline when one surgeon performs the approach and the other surgeon performs the definitive procedure and another performs a repair or reconstruction procedure. Yes, each surgeon will report only the code that is performed or only the code specific procedure performed for the specific procedure performed. All right, so there is your guideline. I think this is the final poll scenario during the facet joint denervation procedure. Physician ablates two medial branch nerves that supplies single facet joint. What should be coded? Report one code for each nerve treated. Report only one code for facet joint regardless the number of nerves treated. Option C, use unlisted procedure code. Option D, report two facet joint codes. What say you, coders? This is the last scenario. Give your best answers. Okay, all right. Good one, good one. Yes, it's the correct answer is option B. Report only the code for the facet joint, regardless number of nerves treated. Yes. So the guideline says although two nerves innervate each facet joint, only the code may be reported for each joint innervated, regardless the number of the nerves treated. So That is your answer. Excellent. Yes, I can see the answers are still coming on. So wonderful job, coders. So if you enjoyed the video, I hope you really enjoyed the video today. And please don't forget to smash that like button and also to subscribe to our channel and share it with someone. Share this video with someone who really need to see this. And I've placed the survey link in the chat, coders. Please go ahead and fill out the survey form. If you have any questions that were unanswered, you can mention them in the survey form as well. So please go ahead and like this video and share as well. All right, coders. So we will see you, or we will meet next week with some new topics and something new to learn as well. So till then, stay safe, keep coding, and take care. Thank you everyone for joining. Have a great rest of the day.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around.